The title of the talk is Leveraging Novel Reproductive and Pregnancy History and Stratifying CVD Risk Across the Lifecourse. It's really an honor to be here, and as Marcia mentioned, I've known her for so many years. I want to say I met you when I was coming out of residency, so that was an awful long time ago. And I mark that because I was pregnant with Layla, I think, and she's now 20, so it must have been 20 years now that we've known each other. So my talk is a little bit of a smorgasbord. I want to cover some sex-specific healthcare gaps, talk a little bit about unique cardiovascular presentations in women as we're thinking about the links between reproductive history with CVD, and then, of course, concentrate on pregnancy and cardiovascular disease, and then also talk about this across the life course of women. And this talk will touch upon discovery, clinical care pathways, health system approaches, because I now work for a very large health system in New York, as well as hopefully spur some ideas for future research and maybe get some of you interested in this area. So what's unique about women? Well, our risk factors for cardiovascular disease, while some are similar to men, they're in terms of the well-established risk factors. We have under-recognized risk factors, which are in the sort of light orange square. But what I wanted to concentrate on today was the sex-specific risk factors for cardiovascular disease. We'll talk about that in a minute. How are CVD phenotypes different in women? There are some that are more unique and common in women, and some of those include an umbrella term called ANOCA or MANOCA, and this is ischemia or myocardial infarction with non-obstructive coronary arteries. This affects about 30 to 50% of people who undergo angiography. So when we bring individuals to the cath lab and we have a very high suspicion that they have coronary artery disease that's obstructive, that is blocking the flow of blood in their epicardial arteries to the myocardium, 30 to 50% of them do not have an obstructive lesion. And it's also true that 5 to 15% of all heart attacks are from MANOCA, so from this umbrella of conditions I'm gonna go into in a little bit. And this whole sort of group of diseases more commonly affect women than men. So 75% of patients that present with this umbrella of conditions are women. Another unique phenotype that occurs 100% in females is pregnancy-associated cardiovascular disease. This includes peripartum cardiomyopathy, many types of myocardial infarction. It's rare, so MI is rare in pregnancy, but this can be from obstructive cardiovascular disease or from a condition called spontaneous coronary artery dissection, which is also more common in women. And then finally, you can have an acceleration of underlying structural or arrhythmic cardiovascular disease. Another condition that predominantly affects postmenopausal women is stress or Takotsubo cardiomyopathy. And that is a condition where classically somebody gets bad news or maybe is in a natural disaster or can be affected by an acute illness. And they will have a form of heart failure and sometimes even cardiac arrest that presents just like a heart attack, but there's no obstructive disease. There's also menopause-related symptoms, risk factors, and sort of that acceleration of cardiovascular risk during that perimenopause period that's unique in women. So getting back to this ANOCA and MANOCA, what are these conditions? I sort of created a diagram here. So they include things like the spontaneous coronary artery dissection, which I mentioned, but two common causes are microvascular disease. So that's disease of the blood vessels that come off the epicardial artery. So it's the tributaries of the larger arteries in the heart. but we can't see them with the naked eye. So there are diagnostic tests that we can do. The gold standard is doing a test in the cath lab where we inject adenosine into the coronary arteries, and we can measure microvascular disease. Another condition is vasospasm. So it's just what it sounds like, spasming of the epicardial arteries or the microvasculature. And then there are other conditions listed here that are in that bucket. The reason I put our program here is just to really illustrate the point that these are common. This is not a niche program, in my opinion. This is something that needs to be expanded, both in health systems, in hospitals, and around the country, because we're not serving our patients if we don't have these diagnostic capabilities and if we don't have people that can treat these conditions. So at Northwell, since I came, we expanded from 1 hospital across to 7, and we now have 15 cardiologists that diagnose and or treat INOCA and MINOCA. So getting back to pregnancy, which is another unique phenotype. Pregnancy is a stress test. So if a woman undergoes a pregnancy and has an adverse pregnancy outcome that are listed under this number 1 group of bullets, then she's at a higher risk for developing cardiovascular disease than the woman who has an uncomplicated pregnancy. So pregnancy is connected with later cardiovascular disease through the unmasking of these conditions. And then pregnancy can also unmask a pre-existing cardiovascular disease, which might not have been appreciated prior to the pregnancy. So pregnancy is a stress test in those 2 ways. And when we think about the relationship between pregnancy and CVD, I like to think of it in terms of this triangle. This is at the tip, just like the tip of an iceberg, a small amount of what we see, but it's obviously very serious, which is that CVD accounts for about 1/3 of maternal deaths. And in the United States, this is important because if you appreciate this rectangle here in this histogram graph, our rates of maternal deaths are much higher than other similar income countries. And in the United States, Black women bear a high burden of maternal deaths. So that's just important background to know about. I think in terms of targeting this area, it's really important to consider quality initiative programs and system level changes. And then the second part of this triangle is really that unmasking of pre-existing cardiovascular disease. And this can include structural cardiovascular disease. And this complicates about 1% to 4% of all pregnancies. And it's definitely becoming a lot more noticeable as women are older and entering pregnancy with more cardiometabolic risk. And then finally, this is really the largest group here, and this is the 10 to 20% of women that will have a health issue during pregnancy that can increase her risk for developing CVD. So in terms of thinking about that middle bar in the triangle, this is the structural heart disease in pregnancy. Many of us in the field have seen this evolve to the point where the best way we've sort of come together and realized to take care of these women is to really form a high-risk cardio-obstetrics program. And I think there's a really nice one here at Stanford. I was privileged to be part of the one at UCSF, and then we have started a similar program at Northwell. So we see patients in an integrated fashion with MFM. My MFM colleagues are here at the bottom here. So that's Kara Pessel and Yaseman Yagubian. And then we have our ACHD group of cardiologists over here on the right. And then here are our cardio-obstetrics women's heart experts here. So we essentially see patients together with one cardiologist and one MFM, and then, if necessary, an ACHD specialist, a congenital heart disease specialist. So we believe this is the best way to take care of patients with these conditions. So it defragments care, and it also allows for a better patient experience and I think a safer pregnancy. So in addition to all of that background, it's important to recognize that cardiovascular risk factors in women occur across her life course. So they really begin in the womb. And the way that I think in epidemiology we think about this is Barker's hypothesis. So Barker noticed, he's a famous epidemiologist, and noticed that children born during the Dutch famine had worse cardiometabolic health and a higher burden of cardiovascular risk factors compared to individuals born either before the famine or after the famine. And we see this play out, and we can extend Barker's hypothesis when we consider the intergenerational transmission of cardiometabolic disease. In this example, it's the transmission of insulin resistance from a child born to a pregnancy complicated by gestational diabetes, and this manifests in an increase in type 2 diabetes in that child, and increased risks of GDM from one generation to the next generation. There's been studies that have now shown us that there are epigenetic changes to that individual, and so this is sort of like a well-accepted phenomenon now. This data also shows us that if you are born in a pregnancy complicated by a preterm birth or shorter gestational age, you have a higher systolic blood pressure or diastolic blood pressure. And this data is from Swedish women that are conscripts, so they entered the military service and they were able to connect their gestational age to blood pressure at age 19. Now, kind of moving on from the fetal period into youth, there are the risk factors that I list on the slide. And in the interest of time, I just wanted to point out one that I think is somewhat fascinating, and that's really this connection between teenage pregnancy and cardiovascular risk, both risk factors and CVD. So this is where I think the Women's Health Initiative was sort of thinking beyond its initial charge of looking at chronic disease in the peri and postmenopausal state. It also allowed us to look at things like age at first birth with later coronary heart disease risk. And this study showed that there was an increased risk there with the referent age at first birth of 25 years. And data from around the world, an international study showed that age at first birth less than 20 years of age was associated with a higher Framingham risk score than older ages. This data from NHANES gives us a suggestion of why that might be. So women that had teen births tended to have a lower prevalence of normal weight and a higher prevalence of overweight or obesity. We really don't know why this is. There is probably some socioeconomic confounding, but we also know that there's greater gestational weight gain for teen moms and greater weight retention as well. And I think one of the hypotheses is that when you have a pregnancy and you're still growing yourself, you're competing with the baby for energy. And so it might be that there's an overcompensation of like weight retention and deposition. So that's just one theory. Teenage moms also have an increased risk of preterm birth, low birth weight, and eclampsia as well. So moving on to the reproductive periods, I just wanted to point out a few different risk factors for cardiovascular disease that I think are interesting, and we might hear a little bit more about infertility, or at least I want to point out that Emily Lau, one of our other speakers, has done some really nice work in this area. So this idea of number of pregnancies in cardiovascular disease is what got me initially interested in this area. So this was the subject of my F32 way back when. During fellowship. And what we looked at there, as well as in the context of some other work at that time when I was a postdoc, was number of pregnancies or parity in cardiovascular disease. We looked at this in the Swedish population registers, and 1.2 million women and showed that there was a J-shaped association between parity and cardiovascular disease with the nadir of risk at 2 pregnancies. This was not the first study to show this. Others had suggested this as well. This was just the largest study at the time. We extended this to show that number of pregnancies in the multi-ethnic cohort of atherosclerosis was associated with left ventricular remodeling. So during pregnancy, there is natural LV remodeling. So in order to accommodate increased blood volume and the shunt to the fetus and all of those demands, the heart grows. So there is a noticeable increase in LV volumes, left ventricular volumes, and then an increase in LV mass. But we showed in these midlife in the multi-ethnic study of atherosclerosis that there were subclinical changes that could still be measured on cardiac MRI. So this was sort of that first hint that maybe all those changes you have in pregnancy don't go away completely. There might be some changes that still persist on a subclinical level. And then we carried this forward using WHI data. So we looked also at electrical remodeling. And it turns out in Women's Health Initiative, there's EKGs that we were able to look at and do some analysis on. So the EKG can show us about atrial remodeling of the top chambers of the heart, as well as ventricular remodeling. And so we were able to show that if you had had 5 or more live births in Women's Health Initiative versus 0, there was an increase in your PR interval or your atrial remodeling. The atria get a bit bigger probably. And there was also a graded association with a longer QT interval, and that is a reflection of ventricular repolarization. So number of pregnancies was associated with electrical remodeling as well as myocardial volumetric remodeling. And then finally, Philip Hall was one of our fellows at UCSF, and he went on to become an interventional cardiologist at UNC. And he had, supported by an ACC Merck grant, looked at this question of number of pregnancies and heart failure, and found that among women that were nulliparous, there was an increased hazard of having heart failure. So this was all the work on number of pregnancies and CVD. We were also interested in the left-hand side of this J-shaped curve. So why were women that were both nulliparous and primiparous at an increased risk, albeit a modest risk, of cardiovascular disease? And we hypothesized that this might have something to do with impaired fertility, maybe polycystic ovarian syndrome, thyroid disease, depression. There were lots of different reasons that might be the case. So again, using the Swedish population registers, we were able to leverage data on over 800,000 women who were parous, with a median follow-up of about 12 years and past delivery, and show that there was this age-adjusted association of CVD rates per 1,000 with years of subfertility. And in analyzing this data in a multivariable model, we found that if you had reported 5 or more years of subfertility, you had about a 25% increased risk of CVD. But we weren't really sure what was behind all of this. So this was taken forward by Gaia Murugapan, who had done, I think, her REI fellowship here and a couple years of faculty here at Stanford as well. And she showed that if you looked at Women's Health Initiative and teased out that the different categories of being nulliparous and then also pregnancy loss, that the women that had reported nulliparity with pregnancy loss had the highest rates. Oh, excuse me, it's this group of CVD, and that was 1.36. So it could be that it's not always the infertility per se, but maybe someone's thinking that they're infertile, but actually getting pregnant and then losing that pregnancy. So there was a signal of that. And then Emily Lau took this forward and showed that infertility was associated with heart failure, particularly with preserved ejection fraction. So that's an important contribution as well, and I think needs to be teased out. We need to understand this area better. And then the pregnancy loss was always something that interacted certainly with fertility, but had been shown by many studies to be associated with CVD. Philip Paul also took this forward and showed in Women's Health Initiative that women that had reported pregnancy loss compared to not had higher BMI, more hypertension, higher systolic blood pressure, diabetes, hyperlipidemia, had worse SES status, and higher rates of depression. So there were some other risk factors that might explain that. And this work was sort of when I first, so this isn't like a temporal talk, but this is when I think when I first sort of became associated with the Women's Health Initiative. And we were really interested at the time in, could we take some of these reproductive and pregnancy risk factors and create a risk score? That was my initial idea, because I had done my postdoc at the Framingham Heart Study, which was all about risk scores. So we thought, okay, can we leverage like the female-specific information and use this to predict risk? And that was kind of the idea behind this study. So we looked at this. Established risk factors were really hypertension, diabetes, the things that go into like the established cardiovascular risk scores. Age, of course, is very important. So when you look at a model that's similar to the Framingham risk score, in the WHI, it gave us a C statistic of about 0.72, which is about what you'd expect for that type of risk score in an external cohort. But as we started to add the reproductive risk factors like age at first birth, number of stillbirths, number of miscarriages, breastfeeding, which is protective, and then all of those risk factors, we only really brought that C statistic up from 0.726 to a whopping 0.730. So it wasn't that exciting. But we still thought to ourselves, in many people, that reproductive history exists before the onset of the risk factor. So it's this early window into later cardiovascular risk. And that's still the way I think about it. Because when I have the 35-year-old woman in front of me, she might not have developed diabetes or dyslipidemia, but we could still leverage her reproductive history to predict her risk. And so that's where I think the excitement is still for us. This is a message I tell my patients because they're excited to hear it. And sometimes it motivates them to breastfeed when they're just about ready to give up. But that's that breastfeeding reduces cardiovascular risk, at least in epidemiologic studies. For each additional month of breastfeeding in this meta-analysis, there's a 10% lower risk of cardiovascular disease across these studies. So there's really many intersections of reproductive and pregnancy history that are associated with CVD. And this was reviewed in this scientific statement by the AHA back in 2021. And looking at hundreds of studies, and Mark Latke was part of this as well from Stanford, so he was an important part of this paper. We reviewed these hundreds of studies, and there was high strengths of evidence that these reproductive factors listed here, hypertensive disorders, gestational diabetes, preterm delivery, SGA, large for gestational age, maybe a little less evidence for placental abruption, and then pregnancy losses were associated with cardiovascular disease. So that was the gist of the conclusions. But where does that risk originate? What's the chicken and what's the egg? Is it that these people have higher pre-pregnancy risk factors? Does the risk occur peripartum? Are there like epigenetic changes or biologic changes that happen as a result of that adverse pregnancy outcome? Or is there a higher trajectory postpartum of risk factor development? It's really hard to answer that in one study, but I think EPIC has done a really nice job in many ways of this. But I think there's also evidence for each of those things being true. So it's probably not that one thing is. There's data to suggest that pre-pregnancy blood pressure has a linear relationship with preeclampsia. I don't think that's that surprising for the OBGYNs in the room. There's also evidence to suggest that elevated serum lipids are associated with a higher risk of preeclampsia. And we showed in the in a preterm birth cohort in California, this is work by Ann Rolfing from UCSF, who's now in palliative care, that early pregnancy, I should say, CVD risk factors predict preterm birth, one of those adverse pregnancy outcomes connected with cardiovascular disease. And then this is data trying to look at that middle section. Does something happen in pregnancy that changes a woman's biology? So we used data from Alyssa Eppel's MAMA study. She's a colleague in the psychiatry department at UCSF. She's done some really nice work in different areas, but we were able to leverage this cohort that had biomarker measurements during pregnancy. We called it -6 months because 0 was delivery, 3 months postpartum and 9 months postpartum. The solid line are women with adverse pregnancy outcomes, and the dotted line are women with normal pregnancy. So we looked at glucose, insulin, blood pressure, and other markers such as HOMA-IR, BMI, IL-6, and TNF, and found that amongst those, glucose had a higher trajectory in the women with adverse pregnancy outcomes, as did systolic blood pressure. So we used mixed model regression, trying to hold constant that first time point to really look at a difference in trajectory across these 3 time points, and found that there is a difference in trajectory for glucose and systolic blood pressure. So we felt that that might be a suggestion of a change in biology because of that APO per se, the adverse pregnancy outcome per se. And then again, this statement had reviewed the association between the adverse pregnancy outcome and then a cardiovascular risk factor later, and found that most risk factors those levels were elevated later if you had an adverse pregnancy outcome. And there was some interaction as well between different adverse pregnancy outcomes, so that if we looked in, again, the Swedish data, if, for instance, you had a baby who was born very small and very preterm, those 2 things interacted, and you had a almost 3-fold excess risk of CVD compared to a woman without those 2 factors, and the interaction was significant. There's also race-ethnic disparities that we must acknowledge and study in adverse pregnancy outcomes. So these outcomes are more prevalent, such as preeclampsia in Black women, gestational diabetes in Asian women, and not just Asian women, but when you disaggregate in South Asian, Vietnamese, Korean, Chinese, and Filipino women, but maybe not in other Asian subgroups. Preterm delivery is more common in Black and Hispanic women, and cardiovascular disease, including MI and stroke, also have important race-ethnic disparities. So what do we do about it? Well, what I think many centers are starting to do is to try to take and recognize the women with the adverse pregnancy outcome and then modify her risk factors in that early postpartum period. So some people call it the 4th trimester, but it's really not just sort of saying, okay, you have your 6-week visit with the OBGYN and then see you later, see you when you're in midlife and you're back with your PCP, but rather let's understand that you had preeclampsia or gestational diabetes or these other APOs, and let's try to modify your risk during that early postpartum period, maybe get you in healthy shape for your next pregnancy, maybe prevent the onset of the risk factor in cardiovascular disease altogether. So that's really the idea here. All right, so that was the reproductive period. So moving forward in the life course, wanted to point out a few things about menopause and also some exciting news from the mammogram that might reflect a cardiovascular disease early risk, or even prevalent, concurrent risk. So menopause and heart health, what's the story now? So menopause accelerates heart disease risk. There's data from subclinical measurements, carotid plaque, that increases in late perimenopause. The cholesterol goes up as well as vascular stiffness, and then there's a change in adipose distribution. Lean mass decreases, fat mass increases. Vasomotor symptoms are associated with cardiovascular disease. We don't entirely understand why. And then other features of the perimenopause and menopause period, such as depression and mood disorders, as well as sleep, change in menopause, and those are associated with CVD. We don't recommend hormone therapy for the primary prevention of cardiovascular disease because still large trials and meta-analyses have shown that there's an increased risk in stroke and venous thromboembolism. But there's no apparent increase in cardiovascular disease if we give menopausal hormone therapy closer to menopause in the appropriate woman with low or intermediate risk with shared decision making. So we like to take this green, yellow, red light approach and look at the patient as an individual and personalize our discussion with her about what the risks and benefits are of hormone therapy. So that was just that in a brief nutshell. So what about breast arterial calcification? So the mammogram, as everyone knows, is used to screen for breast cancer. But we're now also recognizing that we can read breast arterial calcification. So that's these train tracks that you see here on the mammogram, and this is calcification in the media of the breast arteries. And it's a fairly common finding. It has a strong association with coronary artery disease, stroke, and other cardiovascular phenotypes. The mechanism isn't entirely understood. It's not calcium in the intima, it's calcium in the media. So it's a little different than coronary calcification you see on a cardiac CAT scan. It's not consistently reported by radiologists, and there's really no formal guidelines for regarding the reporting. At Northwell, based on a strong patient preference for getting the information, we now universally report back. It takes about 3 to 5 seconds for our radiologists to read it on a mammogram, in addition to everything else they're reading. So we felt that it didn't present such a high burden. So we have identified about 14,000 patients with BAC because it has about that prevalence in our population. So we'll have a fairly large database to investigate this issue, and potentially this might lead to new clinical standards. And I really do feel that other systems could easily report this. And so we wrote this up in an editorial called Giving Women What They Want. And that was really behind the decision to do it. We have a patient-friendly reporting system so that it explains the caveats of the finding and then suggests where to go for further risk stratification. And then we also propose an algorithm for the clinical management of these patients. And we use it really to reclassify a patient from low to intermediate, potentially to high risk. So it's a risk enhancer. And then finally, towards the end here, I'm going to talk about older adults. And I really just wanted to bring Women's Health Initiative back into the conversation. We were able to, with Marcia's support and help, we, on Form 158 of the Women's Health Initiative, we were able to send a survey out, I want to say in around 2016 or 17, I think, right? Where we asked about adverse pregnancy outcomes. So we really asked, it was sort of a ever, never kind of question. Have you ever had a preterm birth, a small baby or large baby? Have you ever had preeclampsia or gestational hypertension? So we were able to get data from the Women's Health Initiative, and this was first written up by one of our Danish American Research Award medical students named Mark Sondergaard, who worked with both Mark Latke and I, and amongst the 161,000 WHI participants after exclusions and looking at responders of the survey, we had about 46,000 women who answered the survey with usable data. And we really thought, like, these women are now 70, like, is this even going to show anything? But we were surprised by the finding that gestational diabetes, low birth weight, having a preterm delivery or hypertensive disorder still was associated with cardiovascular disease in WHI in these older women. So this history of the APO is still important, even in an older woman, independent of established risk factors. And then we had another Danish researcher named Alexander Hansen, and he showed that if we looked in our adjudicated heart failure cohort, resulting in about 10,000 women, hypertensive disorder of pregnancy, or HDP, was associated with heart failure, and particularly heart failure with preserved ejection fraction, which we see more commonly in women. And in a mediation analysis, he showed that hypertension mediated about a quarter of this association, coronary heart disease about 23%, and body mass index 20%, and diabetes didn't really explain much of that association. So what do we do with all of that information, all of these risk factors that occur across the life course? We can use them to refine a woman's cardiovascular risk. So if we have a risk score now, Framingham's out of date, and we have something called the PREVENT score that has been put forth by the AHA and ACC. If we have the woman with a high risk, we already know what to do: intensive risk factor modification and a statin potentially, maybe an aspirin, depending. But a lower intermediate risk, we might use all of these sex-specific factors that we learned about today and do additional testing to better refine her risk, and then treat accordingly. And then, of course, shared decision-making is always important. So finally, it's really important to consider, I think, the life course when we're thinking about prevention, diagnosis, and treatment, and that's what we try to do at Northwell and the Katz Institute for Women's Health in our clinical programs. They're listed kind of near the arrows as well. So in conclusion, cardiovascular disease is the leading cause of mortality for women in the United States. I think this is the first time I'm mentioning that, sorry. It's important to recognize classic and unique CVD phenotypes in women and institute evidence-based timely care. 30 to 50% of patients who have an invasive assessment for coronary artery disease have no obstructive disease. ANOCA and MANOCA are more common in women than men. Pregnancy and menopause have unique cardiovascular presentations. And then reproductive and pregnancy factors are important across a woman's life course. We don't understand the mechanisms entirely, and Women's Health Initiative remains a powerful research resource. Hopefully all of you will use it. So thank you for listening. These are many of my colleagues at Northwell, members of our Women's Heart program. Thank you so much.